Dr. Moxie? Hello?
We're all here, Dr. Morrow. We're trying to get started.
Oh, okay.
Dr. Neighbor.
Good afternoon, everyone, and welcome to this afternoon's version of Black Health Trust, January 23rd, 2022. We're so happy to have all of you with us and that you chose to spend some time with us. We are going to have another exciting afternoon. We are going to be discussing some of the aspects of long-term COVID and how it may impact us going forward. Without further ado, I will turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone, and thank you for joining our co-moderators, Dr. Neighbor Stevens, Dr. Walks, and Dr. Hines. And I especially appreciate our guest of the day, Dr. Morrow Salafu. Dr. Salafu is, I don't know if the correct term is the chairman of the Department of Medicine at the University of Downstate University, State University of New York, Downstate Medical Center, Health Sciences Center, or if he's the chief of medicine. But either way, he's one of the most accomplished and brilliant physicians in the country. And we have cardiologists, we have neurologists, psychiatrists, but the top medical profession is generally agreed to be nephrology, and he happens to be a nephrologist. So welcome, Dr. Morrow Salafu. And before we talk, we were discussing before the meeting where the country is going. And in just a brief moment, if you had a loved brother, sister, mother, father, or child, and they were vulnerable to an illness, would you, if you loved them, wear a mask to protect them, get vaccinated to protect them, as opposed to insist on your freedom to infect and spread anything that you could? So my supposition from that thought is that a great group of people don't care. People who give information that is wrong don't care. These people, many on the right, some on the left, some on neither side, but just misinformed, are attempting murder on people that we love. And I believe we should treat them as such. But our subject today is what happens when you sometimes asymptomatically or symptomatically get COVID and you survive the immediate acute syndrome, you survive the ICU and the respirator. Is it over then? Well, we know that it can continue, and sometimes it's mild and sometimes it can even cause death. Of particular interest, it can happen at any age, and it can cause cognitive decline. It can cause strokes and any number of things. And our speaker today will address all the questions that we have. I want to be clear that just because you don't end up in an ICU, that may not be the worst thing about COVID. So without, to use Barbara's name, without further ado, I'm going to ask Dr. Neighbor to briefly give us our statistics, and then we'll have, as Dr. Pointer said before, the next voice you'll hear is Dr. Morrow Salafu.
All right, Simon, if we could see the slides, please. And while he is pulling them up, I'm going to go ahead and start discussing the most recent statistics available from the CDC website. Total cases since the beginning of the pandemic, which yesterday, I believe it was, or the 21st was the second anniversary of the first reporting of a case in this country. We have had 70,206,222 cases, 12.1% of which were attributed to African Americans. New cases as of January 21st was 700 and 69,153. Let me clarify that. That is on that date, reported new cases, 769,153. Since the beginning of this pandemic, we have had 862,495. Sorry about that. 13.4% of those deaths were attributed to African Americans. As of the 21st, there were a reported 3,506 deaths. When we look at the scenario regarding the status about vaccination in this country, and we are still wrestling with how we want to define this and describe this. So let me be very specific and say that when I say fully vaccinated, the CDC is considering fully vaccinated to be those individuals who have completed their series of 2, if it's a 2-dose vaccine, or the first and only dose of the 1-dose vaccine. So as of the 21st, we had 210,229,586 US citizens that were fully vaccinated, which represents 62.9% of the total US population. Of that number, 9.9% are attributed to African Americans, and we have 39.7% of the US population that is eligible for booster doses to have been boosted. So again, we are saying we have a long way yet to go when we talk about utilizing the tools that we have at our disposal to protect ourselves from this disease. That ends our data for the day.
So
Thank you,
Dr. Maxey, I just wanted to expand a little bit on the information Dr. Naybert-Stephens just presented. I think that we are behind a little bit as a country in how we use the term fully vaccinated. Because as Dr. Naybert-Stephens pointed out, fully vaccinated currently means you've had 1 dose of the J&J vaccine. And we know that if you've only had 1 dose of the J&J vaccine, you may be fully vaccinated by definition, but you are not very well protected. And we should be very clear about that with anyone who feels I can get into places, I'm fully vaccinated, I had my 1 dose of J&J, you really need a booster to consider yourself having any significant amount of protection. Likewise, if you've been fully vaccinated with only 2 doses of Pfizer or Moderna, you may be a little bit better protected than the person with 1 dose of J&J. But even though you can get into places with your vaccination card, you are really not very well protected. So maybe the CDC is still looking at the term fully vaccinated, but maybe we can begin looking at a term like best protected, so that we can really be clear with folks what it means when you've had 2 doses without a booster or 1 dose of J&J without a booster. I don't know, Dr. Maxey, is that a fair place for us to stand?
Well, I think we ought to just say that we think being fully vaccinated is to have all of your pre-vaccinations, meaning your 2 doses of RNA vaccines, your 1 dose of J&J plus a booster is fully vaccinated, and maybe not enough. I think we should not be political like the CDC. And so I think you're right on time. Fully vaccinated may not be fully protected. Fully protected means you've had the booster and you may need more. But let's go to our guest and we can put some of those questions to him. Dr. Morrow Salafu, how are you, sir?
Very well. Thank you very much for inviting me. I truly appreciate that. Unfortunately, I have to apologize for not being on video today. I'm not in my regular location to be able to do what I'm supposed to do usually, but I'll be able to get through the questions and be able to take as much as I can and be able to show you some few slides to remind you of the danger that we are still facing with the COVID-19 pandemic. I want to make a few remarks before we get into the details, which is that you talked about some of the, some citizens who take the freedom into their hands and they want to say that they are too free to do whatever they want. But I think the problem is really the definition of freedom, right? That is where the problem is. Those individuals don't think that other people have the freedom. Your freedom ends or begins when ends when another person's freedom begins, right? So it's an overlap. So if one thinks that you're too free, then what is the sphere of the next person around you? Is that person also free to say that you should wear a mask or not? So I think it is the definition of the freedom that is causing this problem. And those people who are not interested in vaccinating or following the social distancing principles are those who don't understand what freedom really is. If they understood what freedom was, they would never put another person at risk, because they know that, another person's freedom would be at risk if they do so. So hopefully they understand someday. Well, I have a few slides to remind you of the pandemic. I have shown these slides before, so I don't want to belabor them too much, but I just wanted to share a few slides before we get into the main topic. See what I can project these slides. Just 1 second. I hope you can see this slide.
Yes, we can see it.
Okay, very good. So just to remind the audience that there has been an evolution of how we think about the transmission for COVID-19. Initially, when it hit in January of 2020, and subsequently the surge in March of 2020, it was all about droplet transmission, which is right in the middle here. And later on, we realized that contact was quite serious, and now it's almost everything. So I just wanted to remind everyone that it's no longer any particular mode of transmission. The contact transmission really is when you have direct contact, such as a handshake, touching a surface that has been contaminated and the like. That is direct transmission if you happen to be unlikely to have the virus around. The droplet transmission refers to larger and smaller droplets and particles exhaled by some person who is infected, and it stays in the air for some time before it goes down, and that distance is about 6 feet. That is why, during the surge in 2020, March, April, and May, the song was 6 feet, stay within beyond 6 feet of, you're the next person. That was the rationale for the social distancing recommendations by the CDC and then and other agencies. But now we know that it's not just the case, right? There's also airborne transmission that has, is able to take the virus that are very, in small sizes and particles. They can remain suspended for long periods of time and can actually travel longer distances, more than 6 feet. Some of them can go as far as maybe 30 feet, 40 feet, depending on the actual size of the virus and then the strain of the virus. For instance, we now know that the Omicron actually is really, really very small. It can actually stay in the missles of the droplets and be suspended for long periods of time compared to the Delta and the Alpha variants. So for now, there is really no separation. Everyone should know that there's really no separation. You can actually get infected by any of these means, by direct contact, by droplet infection, or by airborne transmission, depending on how close you are with the person who is primarily infected. Okay. So this is how it works. So these are the very small particles, right? These very small particles can actually go very long distances. And now we know Omicron is actually very small particles, and so it can go very long distances. The medium droplets would probably go down within 6 feet, and then the large droplets are basically, when you cough or sneeze, they are basically on the ground. So this was the basis for the recommendations for the social distancing. For the contact, it depends on the surface. So this is just to illustrate how vulnerable we could be depending on the surface that you are in contact with, right? So this is aerosols, this is copper, this is cardboard, stainless steel, and plastic. You can see that the surface that we are actually in contact with on a regular basis, that is stainless steel and plastic, is actually the highest in terms of the half-life of the virus. When they stick to these plastics and stainless steel, they actually stick around for a long time. So we have to be worried about it and make sure that we're cleaning our hands, sanitizing, wearing the mask. All those things are very important in all these pathogenesis, because if you have to take care of the contact transmission, it means you have to keep washing your hands and sanitizing when you have contact. If you want to take care of the droplet and the airborne, you have to really wear the mask, because things can get through. Now, it now depends on how we are able to get high quality masks to people. In the beginning of the pandemic, that is the March to May, because there was no preparation whatsoever for personal protective equipment. Anything that we got, we did. Anything that we could do to prevent infection, we did, including cloth face masks, right? So, but now we know a lot of these masks are not really protective. So you have to really get a high quality mask. And the high quality mask, especially for the Omicron, is not the, the regular face covering with a cloth. It is probably not the regular mask that is not a surgical mask. The surgical mask probably confers a little bit of protection, but it's not the mask for Omicron. The recommendation right now is a high quality N95 or KN95 or similar kinds of mask to prevent the Omicron from penetrating through the layers of the mask and getting to you and getting you infected. So, but in the end, a mask is better than no mask, right? It's just a matter of the quality of the mask. So in the end, a mask is a mask. And if you can get hold of the higher quality mask, then that should be your mask in terms of preventing the aerosol transmission. Then there is another area that we have to remind ourselves, which is, comparing, what happened in the beginning, the Alpha, the Delta, and then now the Omicron. If you have one person that is infected, what happens to all the people around that person? This was for the original Alpha variant. So one person could infect about 12 people, right? If you have one person and you're really close to each other within 6 feet, that person could infect 12. And Delta actually multiply that by 10. So you could infect 120. And Omicron amplifies that by another 10. Right, so Omicron is really, really serious. In other words, if there was one person here infected with Omicron and there was this closeness, there's a very high chance that everyone will get infected. Very, very high chance that everyone will get infected. So it is very important for people to understand these principles, that the virus is emerging and it hasn't stopped, changing, because we are also fighting back. So it hasn't stopped changing. And anytime it changes, it tries to become more virulent. Hopefully, this surge with Omicron will die off in a few weeks, but who knows what holds for the future. And so these issues need to be understood and practiced so that we can protect ourselves, protect our families, and stay safe altogether. All right, so this is my last slide talking about, crowding. Crowding is really a big deal. Anytime we have people in a very crowded space, it is actually a recipe for transmission. So it doesn't mean that we cannot live with our families and enjoy our families and all the social activity that we need to do, but it just simply means that we have to be vigilant and be cautious. Just as an example, before you get into the plane to fly from LA to New York, what did you do? I mean, they would ask you whether you have your booster, they would ask you whether you have your mask on, and if you don't have your mask on, they're not going to allow you to board the plane, right? And while you're in the plane, they will ask you to keep your mask on unless you're going to eat. And so when you are about to eat, you say, okay, open your mouth and eat. And then when you finish, you close your mouth, right, and your nose. You know, so that is an example of, okay, we need to be together, but we also have to find a way to be together that is not dangerous, right? That's an example of that. We need to be together, but we have to be together in a way that is not dangerous. So we find a way to be together, but also, you know, ensure that being together is not contagious for us in the long run. Okay, so those are the introductory slides to remind you of how serious these the pathogenesis of COVID is, and hopefully we would continue to practice the social distancing, continue to practice the hand washing, continue to practice the mask. For now, any mask is better than no mask, and a high quality mask is better than any mask. So that is the recommendation. Okay, so now the second point I wanted to make was a discussion around the long COVID or post-acute sequelae of COVID-19. Last year, we had the honor of, collaborating with the Black Health Trust from the Brooklyn Health Disparity Center to conduct one of the first symposia on the long COVID syndrome. It was very, very successful. We had more than 13 countries participate in the long COVID symposium, and we were very, excited about that. There is a book in the process. When we get all the authors lined up to finish their chapters, and hopefully the Black Health Trust and Brooklyn Health Disparity Center would have a book in their name addressing the long COVID syndrome in the next year or so. And that will be a major, major advance and credit to all the efforts. So what is long COVID syndrome? Today, I will be taking questions more than talking around the subject, and I would invite, all the leaders here to contribute as much as possible. But it's more of a questions and answer session. But I want to just, define it first, and then we'll take the questions and answers. COVID, the acute phase, typically when we described it initially was, you get the infection by 7 days, you are going to have symptoms, right? You're going to have symptoms. And if you don't have major symptoms before day 12, you're basically okay. And you're probably going to go and recover. But most people by day 7 really had bad symptoms that required some kind of medical care. But those who were able to escape the day 7 to 12 were probably going to recover at home. Then Delta came, and then the acute phase actually shortened a little bit to about 5-6 days, and now Omicron actually shortened the acute phase. It's about 3 to 5 days. So when you get the Omicron, you actually are going to get sicker faster than the original Alpha and Delta variants. And I think that is the rationale for the recommendation for if you have the acute phase and then after 5 days, you are not really sick, you can actually wear your mask and come back to work. That was the rationale for that recommendation. But that is the acute phase, right? The acute phase is expected to recover fully. But in some cases, the acute phase doesn't really go away fully. And symptoms persist after 30 days. And so the definition for post-acute sequelae of COVID-19 or the long COVID syndrome is if you have symptoms that persist beyond the 30-day period. And the symptoms are all over. The symptoms, that COVID-19, primarily affects the epithelium of the lungs and the GI tract, but it also affects a lot of organs. It affects the kidney, it affects the heart, it affects the brain and the nerve tissue. It affects your psyche and your cognitive function. Basically, every single organ system can be affected by COVID-19. But the hope is that it will go away within 30 days. But again, in some cases, and the literature reports up to 50% of time, the 30 to 50% of the time, you could actually have symptoms beyond 30 days. So what could they be? The classic one is persistent cough, shortness of breath, decreased exercise tolerance. Those are all lung symptoms. There are patients who have persistent, cardiac issues, heart rate abnormalities, blood pressure abnormalities, poor function abnormalities. There are the, persistent GI symptoms, but the literature actually talks about the GI symptoms in a very, very positive way. It could last beyond the 2 weeks, but rarely do the GI symptoms actually go beyond the 30 days. So I'm going to skip the GI symptoms for now. But the kidney functions actually do last for longer than 30 days if they do, which is basically some people tend to have a decline in kidney function. A lot of it, we've published actually on this subject, a lot of it actually is transient, but 5 to 10% of the patient will still have, elevations in their kidney numbers, which means that the kidney has been damaged to some degree. We don't have long-term studies to be able to show what this really means, what is going to persist into becoming chronic kidney disease and maybe risk for kidney failure and dialysis. We don't have that data yet, but in about a year or so, we would have that information. And then you go up, the neck, you have the neurocognitive issues, cognitive decline. And I'm sure Dr. Walks would love that conversation when we expand that in the question section. And then the neurologic issues. There are paresthesias, numbness. Those who had a stroke would still have, symptoms related to stroke findings, weakness and decreased strength, tactile function and vibration sense, and all that stuff will decrease over time. But they are there and can persist over 30 days. Okay, so that is long COVID. Now, why is that important? It is important because here we have a disease that has disrupted the system. The medical implications are huge. The socioeconomic, financial implications are huge. And now we have to now develop another system to manage the complications of long COVID, which also have similar devastating complications, either for medical and the socioeconomic aspects of our society. So we are going to be very busy over time figuring out how do we treat patients with long COVID and lungs? How do we treat patients with long COVID and heart disease? How do we treat patients with long COVID and kidney? And how do we treat patients with long COVID and neuropsychiatric issues? That is why it is so important to know these things. The second thing, the second reason for knowing long COVID is it would educate a lot of people to actually take the preventative measures very seriously, because we still don't know how to address these issues, right? We still don't know how to approach and address long COVID in a way that will make everyone comfortable. Okay, you have it, you're going to be all right. We still don't have that answer for everybody. So why get a disease in the first place and be exposed to long COVID, for which the prognosis is unknown and the consequences of all the stuff that I've mentioned are unknown? There's absolutely no reason to be in that category at all. So it also emphasizes the need for prevention, social distancing, sanitizing, and making sure we're wearing high quality masks. Okay, so those are my remarks, and then I will probably go to the questions and answer sessions, and then we'll invite other participants to address some of the issues of long COVID as we move in the hour. So I'll stop here and then we'll take the questions.
Thank you so much, Dr. Salafou. That was very, very enlightening and educational. Dr. Walks, you were one of the task force that worked with Dr. Salafou to put on the conference on long haul syndrome. and you presented some of the neurologic and psychiatric findings. Why don't you start off our questions? I'm trying to get a long haul patient to join us for a moment.
So Dr. Salafu, one of the questions in the chat, and I think we can start there, was you mentioned the different modes of transmission, and you talked about surface transmission. And one of the questions in the chat was really asking for a little bit more information about whether or not surface transmission, contact transmission, was actually still a major concern.
The answer is yes, absolutely yes. And again, the commonest surfaces that we encounter every day is the steel and the plastic, right? Those are the commonest one, right? So you're in the kitchen, you are washing your plates and all that stuff, you're dealing with plastics and all that stuff, you're sneezing around, all that stuff sticks into surfaces, okay? Now, I will not be able to quantify what percentage of the transmissions are, contact related versus the droplet, but it is quite significant in terms of looking at, people who get infected and what they leave behind when they go away from a particular environment. If you actually, there is actually one of the studies they did scanning electron microscopy on people who are infected, and they leave the surface, and then you scan the surface to see what is in there. It is scary what you see on the surfaces for people who are infected after they sneeze.
So and Dr. Salafu, to stay with that concern about the practical, what's going on around us, there was a time when everyone was saying, well, you need to wear a face shield as well. And now we don't hear as much about needing to wear a face shield, or someone will say, well, if you wear glasses, that will help protect your eyes. So can you tell us a little bit about how important it is to cover or not cover our face, and whether we need face shields, and are my glasses just fabulously decorative, or do they actually serve some purpose when it comes to COVID protection?
Okay, so in the initial pandemic, it was, all in, right? All in because we had no knowledge of, the transmission, and people were looking for an immediate solution to the problem. So we did all in approaches to the situation. We now know that people are exhausted. It doesn't mean that the approaches are wrong. It just means that people are exhausted. It's called the COVID fatigue. People are just exhausted with so many, recommendations to prevent the infection. So the face shield absolutely will protect you. The question is, can we get people right now to actually get the face shield, to wear the face shield at the place that they are supposed to wear the face shield, without feeling that exhaustion, without feeling like something, it's just too much on my head. That is where the problem is, not the scientific validity of the face shield. So when I'm in the clinic settings, I wear my face shield. If I am in the clinic, I will be, since December when we had the surge, I see patients twice a week. I always wear the face shield to make sure that I'm either protecting the patient or I'm protecting myself from the patient. But a lot of people don't wear the face shield. So, and I'm not surprised, it's all from the fatigue of all these recommendations. Now, having said that though, I think the high quality mask actually works. So if you have the high quality mask on and prevent your orifices, that is your nasal and oral mucosa, from getting into direct contact with the virus, you are definitely in a better shape. Absolutely.
So Dr. Salafu, the last question. One of the questions in the chat is about whether Omicron can infect all of the same tissues as Delta, and whether Omicron can cause long COVID. There's another question about how can you tell maybe you're going to get long COVID? What are the symptoms? And you mentioned that most folks get better after a certain period of time, but if you pass that time, then you would have long COVID. But it kind of makes me wonder, is that the same kind of question that, it's too late. If you already have it, you're late trying to prevent it. It's all the people who are really, really sick with COVID and asking, can I get the vaccine now? And the question is no. So protection is really the key. But if you're doing everything right and you're wearing your proper mask properly and you're protecting yourself, and then you get COVID, is there anything you can do to not get long haul COVID, to kind of nip it in the bud, so to speak, get through those 5, 7, 10 days and be okay again?
Okay, so I would give the example from the initial surge, that is the March to May of 2020 examples. When we had the surge, the daily death rates in the United States, right, was about 4,000 to 5,000. Okay, that was the daily death rate. Compare that to the Omicron, December through January, we actually get more cases. It's actually double the cases volume that we had compared to March to May of 2020, but the death rate is in half, right? I've been watching the numbers. The numbers are anywhere from 1,200 to 2,000 deaths per day, maybe slightly more than 2,000, but for the most part, it's lower than 2,000 deaths per day, despite being double the amount of, or even more than double the amount of new infections per day. Okay. So what does it tell you? It tells you that something actually happened between the Delta and the Omicron variant, right? Surges. It means something really good happened that protected people, but maybe not enough to protect everybody, but at least something good happened. And what could that be? It meant that we probably learned a little bit more about COVID. That's number one. There's no question around that. We probably learned a little bit more about how to protect ourselves. That is hand washing, the social distancing and the mask. We definitely learned that. And then the vaccine, as we spoke in the beginning of this afternoon session, the vaccines really, really made a big difference. If you have if you are fully vaccinated and you're boosted, and Dr. Maxey has already, exhausted that point. If you are fully vaccinated and you're boosted and you get COVID, you probably are going to have very, mild symptoms. Why is that so? It is so because, think about it, it is an epithelial disease. I said it, but I said it in a very soft way. But I want everyone to remember that word. COVID is an epithelial disease. Your immune protection is inside your blood, right? It's not IgA. There are different kinds of antibodies that protect different areas. The protection for the epithelium, that is the lining of your mouth and your nose, is called epithelium. That's the lining. The protection is from IgA. There's an antibody called IgA antibody. The protection in the blood is different. The protection in the blood is IgM and IgG. That is what you get when you get the vaccines. The vaccines produce IgMs and IgGs that protects you when the virus enters the blood. But unfortunately, the virus doesn't enter the blood right away. It goes through your epithelium first and then into your blood. So it means that even if you are boosted and your antibody levels are high, they are IgGs and IgM, they are not IgAs. So the epithelium is not protected. The way to protect the epithelium is the mask and the social and all that other stuff. But once it gets into your epithelium, it's going to cause some damage, right? But if you are fully vaccinated and you have, boosted and protected, that is high levels of antibody, then there is no chance the virus can make it into your bloodstream and cause a problem. That is where that difference comes. So you will still get some symptoms, but they are going to be mild symptoms because it's never going to cross what we call the capillary barrier to get into your blood and then cause damage, right? It's going to stay in the, do some little damage and then go out. So it's going to be mild cough here and there. You'll be positive, but in the 5 to 6 days time, you're negative again and you're okay. Compared to if you are not fully vaccinated and boosted, your system is open. Your epithelium is open. Your blood is open. right? So the virus gets in contact with the epithelium, does damage, makes its way across the barrier, the capillary barrier, and there's no protection there, so it causes even more damage. And so the chance that you're going to get more disease, that is more serious disease, is much, much higher. So what we learned between the first pandemic, first surge, and now is all those things. We learned the virus to protect ourselves. We learned, we had the, vaccine in the United States right now. I think about 60% of the total population is now vaccinated, but the one dose is about maybe in the 70%. In New York State, it's quite higher than that. So that has actually protected the population. And I think that is the reason why we are seeing a lower mortality. So the answer is, all this long talk is to say that for long COVID, the best protection is really all those things plus the vaccine. That is the long answer. That's the short answer to the long explanation.
Dr. Salafu, you and I have cooperated on a number of patients across the country that you have helped me consult on. And I have a young lady online who's actually a patient of mine. And Simon, if you can unmute Dr. Estes, and just a little history while Simon is doing that, if he can see her. Dr. Estes is a registered nurse. She attained her PhD about 2 years ago in nursing. And I was honored to be her advisor on receiving her PhD. She worked as a nursing supervisor running an emergency room at one of our major hospitals in the Inglewood and Los Angeles area. And she contracted COVID. She was not vaccinated at the time. And she subsequently had a number of events. I wanted her to briefly run that past you, Dr. Salafu, and I think her testimony could give some color to what you've been talking about. Is Dr. Estes on? Are you able to see her, Simon? Or Dr. Walks?
I'm not able to see a Dr. Estes, Dr. Maxey.
Dr. Estes, and if you can hear me, if you could call my cell phone, I would like the audience just to hear you a minute, just your experiences. Can you call me in the next few seconds? So she was listening and
Okay.
She,
can you
Dr.
raise your
Maxey,
hand? Yes.
It's not clear if she doesn't have her name on a particular, there are some of the folks who are on.
Keisha Estes, RN, PhD.
Hold on, here she is here.
Dr. Maxey.
Yeah, Dr. Estes, I've got you on speaker. Can you hear her, Dr. Walks?
I can hear her talking. Yes, Dr. Maxey.
Okay. Dr. Estes, I have Dr. Salafu and Dr. Walks here and a number of our other physicians. And I'd like you just to briefly tell what happened to you after you got COVID, including your surgery, just briefly. And I'd like Dr. Salafu and Dr. Walks to comment.
Okay, I will. Good afternoon, colleagues. First, give it honor to God. I thank you for granting me the opportunity to speak with you all this afternoon. I am Dr. Keisha Estes. I have a doctor of nursing practice, specializing in emergency medicine. I am a director of a very busy emergency center in the area of Inglewood, California. I was running the emergency department and we had an overflux of COVID patients. We only had 3 negative pressure rooms at the time. So when the influx of patients started to rise, we no longer had any rooms to keep them away properly. So the entire emergency department was had an influx of COVID patients. We did have PPE. However, there were times when we were running low, and me and the staff were encouraged by administration to reuse PPE. In October of 2020, I unfortunately came down with COVID. I had every single sign and symptom. My first symptom was dizziness. The following morning, I woke up with a severe cough and mild respiratory distress, and the sputum was yellow. They missed the pneumonia on the initial x-ray and did not find it until 3 weeks later. Luckily, one of my colleagues had already prescribed me some Levoplan initially, which helped me severely. However, each day that passed, I developed more and more symptoms. The headache was the worst headache I had ever endured in my life. My fevers were as high as 105, in which I was taking Tylenol. I had nausea, vomiting, diarrhea, loss of taste, loss of smell. I had no appetite, started losing weight. One thing that was very interesting and concerning to me was my nerves. My arms and hands were shaking really, really bad. I would get this weird feeling and sound in my head, and I was just falling for no reason, just falling. Anytime I got the strength to get up and try to go to the restroom, I just fell, collapsed. My body would spin around on its own, which was quite terrifying to me. And then I would lay there because I could not get up. I had bilateral ear infections. I had been placed on 7 rounds of antibiotics, which did not cure the ear infections. To this day, I still have bilateral ear pain that has not gone away. The shortness of breath just would come sporadically. I never knew when it was coming. I never knew when the dizziness was coming. I never knew when the falls were going to come. One day I fell so hard that I sustained a bulging fracture in the LS area. My knees are still clicking when I walk. This was in November. It lasted practically the entire month of November. They sent me back to work in December, which I wasn't ready. And I almost collapsed at work. So they sent me to the emergency room, and I was diagnosed with sepsis, pneumonitis, and along with some other things. So I've been off work since December of 2020. I took my COVID shot, Pfizer, in December, but I have not been able to take another dose because I've been sick. My white blood cells are constantly up between 14 and 15. Last year, I was hospitalized 7 times. No doctor can tell me why. My blood cells are up. My D-dimers are constantly over 150, 155.
So let me ask you a question, Dr. Estes.
Sure.
And then I want to ask Dr. Salafu to comment.
Yes.
What happened when you went to Torrance Memorial, and what type of surgery did you have and why?
Okay, so I had the shot in December, and I went to see a pulmonologist in March. And I told him, if you don't find out what's wrong with me, I feel like I'm going to have a stroke. And he said, oh, Keisha, you're not going to have a stroke. April 13th, 2021, I suffered a mass ischemic stroke. I was completely paralyzed on my right side. I could not talk. I lost my memory, and I had a thrombectomy performed on me.
You had a craniotomy.
no, thrombectomy.
Okay.
Wow.
And they entered through the groin, and they released me the fourth day because I had regained my usage of my extremities and my memory partially. That night when my mother got me home, I started seizing. So she called 911 and they took me back. And at that time, they kept me for an additional 2 weeks. And the TEE showed that the seizure was coming from the area of the stroke.
Mhm.
I'm still falling. I fall faithfully at least once, twice a week. Dr. Maxey is constantly on my tail if I said I haven't used my stroke. I'm 46 years old. I'm independent, so COVID has really had a negative impact on my life. I feel like I don't want to use the walker because I'm not used to depending on anything.
Let me ask
not
you one more
only-
question, Dr. Estes, and then I want Dr. Salafu to comment. What type of surgery did you have at the hospital?
I had a thrombectomy, and recently on December 21st, I had a TTE. The doctors wanted to do a bubble study to see if I had a hole in my heart, looking for a POF, because that could have been a contributing factor to the stroke, but the procedure was negative. So now it's back to the drawing board. But one thing that it's important that people really, really need to realize with COVID is the negative impact that it has on a person's mental space. I am under psychiatric care due to this and have been diagnosed with major depression as well as anxiety. I don't leave my house. The only time I leave the house is to go to doctor's appointments. Other than that, there are services out there that do my grocery shopping for me. And if I want a fast food meal, they'll deliver that too. A lot of people may call it phobia. I call it playing safe because there's just too much recklessness out there and I'm not getting any answers.
Okay.
And they say maybe I need to speak to an ID, but I haven't had that opportunity.
Well,
and I still have all of these symptoms.
We've got a number of people on. We have Dr. Salafu, who is a chief of internal medicine. We have Dr. Walks, who's a psychiatrist. We've got Dr. Jordan, who's an ID. So Dr. Salafu, I'd like you to comment on what she said.
First of all, thank you very much for sharing your story.
Welcome.
This is brave for you to come into a public forum like this and be able to share this story. This is remarkable because it's a sign that you're not selfish at all. By sharing this story, you have prevented a lot of people from getting to the same situation, and thank you for that. But for you, you are, exemplifying the book that we are trying to write to make people understand the long COVID syndrome. It is not really a joke. These are serious issues. What happens is that COVID-19, even though it's a mostly epithelial disease, when it gets into the bloodstream, that's even close to the bloodstream, it triggers a very, very, very intense inflammation. That's where all this is coming from. If I were to summarize the problem into one word, what she went through was intense inflammation. Even though the virus is gone, the body was still reacting to intense residual inflammation at all levels. From the neurologic side, from the lung epithelium, from the blood side of things, the bone marrow, platelet activation, all that stuff was all occurring, even though the virus was no longer in the system. So what do you do? This is now multi-system disease, systemic inflammatory response. So I can talk offline because we have to have disclaimers for providing non-specific medical treatment without knowing all the information and reviewing. But I can certainly say that the group of the one thing that explains the group of diseases is this intense reaction to the virus that she had. And that explains most of the stuff. So, but there are ways to address that, and I can address those ones. The change in taste and the smell was very classic. A lot of people complain about that. The mechanism for that is, again, direct infection of the sensory nerve cells, the bodies, and then the virus actually destroys them. A lot of it is temporary, though. The nerve cells really rebuild back, but it takes a long time for the nerve cells to regain their bodies back and then be able to perceive the sense of smell and the sense of taste again. But it does come back. I'm so sorry to hear all this stuff. Maybe you also need to talk to Reverend Pointer, and I'm sure he'll be happy to also provide some additional support for you. But I'll be happy to take more questions of that offline.
Thank you. Dr. Walks, she also has severe depression, and maybe just comment on a bit of that as it relates to long haul syndrome and what the approach might be and what type of support she might look for.
Thank you, Dr. Maxley. Dr. Estes, thank you so much. As Dr. Salafu said, it's really an act of unselfishness and an act of kindness to share your story with us. And it's hard to listen to because we can feel the pain that you have continued to go through. And at the same time, it's important for us to listen to it so that we understand just how much of a devastating event you've gone through and that you continue to go through. So my heartfelt thank you for being willing to share with us. In terms of the mental health consequences and the mental health treatment interventions, like Dr. Salafu, to go into specifically what I recommend you do is not what we do in a forum like this. What I would like to say, though, is that the amount of attention you have had to pay to this has overwhelmed everything else that you do. And it's impacted you in very personal ways in terms of the person that you are. You mentioned something that may sort of be just happenstance to a doctor. We'll say, well, look, you need a walker to keep from falling down. But using a walker at 46, I think you said, is challenging. We're not supposed to be using a walker long-term at 46. Some of us would struggle at 66, 76, or 86 to not be able to walk independently. That's huge. And so not being able to work is huge. So these are things that absolutely impact us when we find our personal independence is impacted. And the way we view ourselves, we tend to view ourselves as people that can get up and move around and go places. If you're in Southern California and you want to get to In-N-Out or Del Taco, you shouldn't have to wait for somebody to bring that to you. That's why it's called fast food. You think about it, you go get it. So there are a lot of these things that seem sort of not consequential, but when they happen to us, they really change significantly how we view ourselves. And that's where things like developing the symptoms that actually qualify you for a diagnosis of something like major depression, something like generalized anxiety, that's when those kinds of things happen. I remember in medical school, as we were learning about the different illnesses and diseases, this probably happened to you when you were going through nursing school as well. You start thinking you have everything. I just read about that, I might have it. And one of the things that they told us is there's no diagnosis without dysfunction. So you really need to look at where are the areas where you're having dysfunction. And so for you, you can look specifically at what I used to be able to do and what I'm not able to do. And so that's that difference that defines the dysfunction. So I think it's important to acknowledge that there is a dysfunction. Listen to the doctors who are helping you with defining the specific diagnosis and the specific treatment approaches, one of the nice things about medicine, I know I get a little long-winded, but let me just finish with this one little piece. Whether you're a psychiatrist or an orthopedist or a nephrologist, one of the standard parts of medicine is that we do doctor stuff with medicines, and then we do some kind of therapy along with it. So if it's diabetes, you may get your medicine and you'll get some sort of diet therapy or a dietitian or that kind of a person. If it's orthopedics, you'll get maybe your surgery or your medicine, and you're going to physical therapy. With mental health, you're getting something from the psychiatrist and you're getting some mental health therapy. And I think it's important anytime there is depression or there is anxiety, and the level of anxiety that keeps you at home because you're too anxious to go out because you may fall. That's real. Therapy can help you with a lot of the rebuilding of that sense of self that is taken away when we significantly change how we view ourselves because of some trauma that's happened to us. So without getting any more long-winded, except that, and you probably already have, that the doctor part of it and the therapy part of it, and then all of the nursing and the supports part of it is what good medicine is. It's not just prescribing a pill. So again, thank you for sharing everything you shared. Like Dr. Salafu, I'm happy to talk more about it offline, but I'm happy to know for you that you are following up with the doctors, that you are following up with the opportunity for some good mental health treatment.
And thank you, Dr. Walton. Before I ask Pastor Pointer to comment, I want to just go a little bit further. When Keisha was working on Dr. Estes was working on her PhD, many days she would drive me home because of my own sight impediment. And we would have the best time playing John P. Key, Stand in the Need of Prayer. We would blow the car up with all this gospel music and her strong faith. But what bothered me even more, despite what she described to you of this disability, which came as a result of working at a major hospital and having the best PPO insurance you can have, the hospital refused to honor that insurance, fired her, and she went from being a major supervisory employee to not being covered. The medical director of the hospital was also her pulmonologist. I won't mention his name, but they totally screwed her employment-wise. And so she had been put in not only a bad health situation, mental and spiritual situation. And Pastor Pointer, I know we can only talk so much, but I'd love you to just comment before we go back to our program.
We need Pastor Pointer to unmute. Okay, there we go. Good.
It's amazing that Dr. Estes, you've been able to be as fluid and as lucid as you are, having suffered through this kind of prolonged illnesses, and that's plural, because while the trigger is one illness, what you've experienced is multiple illnesses, and then still to maintain. I can hear in you a common sweetness and an absolute faithfulness, and so you're to simply be lauded for that. And I've heard these stories from others who have suffered from a multitude of illnesses after recovering initially from their bout with COVID, especially those who got COVID in that year leading up to vaccinations. So I want to encourage you, and I'm going to make sure you have my contact, because anytime that you need me, I stand ready, willing, and able to share with you as a brother in Christ and as a servant of the Most High. But just keep your positive outlook and your unbridled faith, and that will do a multitude of things. But let me offer that seek care for your mental health, because we tend to treat the rest of our body, but we don't treat our head. And last I checked, our head is attached to our body. And so it deserves the same kind of comprehensive care that we give to our body. So please seek treatment if you haven't already.
Thank you very much,
I
Pastor
think
Pointer.
I think
Dr. Jordan,
Dr. Jordan was trying to get in, Dr.
yes,
Maxey.
he's waving at me. Dr.
Thank-
Jordan?
Thank you, sir. I heard what you said, and you need to present this story to our supervisor. In this county, the persons that people jump to are the supervisor. They are damn powerful. And
You mean the county supervisor?
I mean your county supervisors. And she needs to hear about this story, because if there's anyone in this county that can get this lady's job back, assuming you're accurate, it's a supervisor. That's the plantation boss.
Mm,
And they will
ouch.
jump. No, I don't know. Washington, D.C. doesn't have that, but our 5 supervisors are extremely powerful. They control billions of dollar budgets. So I'd rather be a LA County supervisor than a senator from Wyoming. The only reason I have any power from Wyoming was that I was a senator for 29 years. Then I might get some power. But the county supervisors here are extremely important. And Randall needs to talk to our supervisor Mitchell. This should not have happened. And we as Black folks too often do not use the right political source that we have. So you need to let this lady meet Holly Mitchell and present that story to her.
Thank you. That is key advice, and I appreciate that. We're near the end of what we're going to discuss today, but I'd like to just go around and see if there are any final comments that Dr. Salafu would make and our co-moderators, and I recognize some of our other specialist physicians on the phone, including Dr. Daz, I see. Dr. Salafu, this has been a great information session, and I hope I can get a copy of those slides. I want to show them to some Republican friends of mine.
I'll send them to you. I'll send them to you.
You have Republican friends?
What you need to tell them is that they should go and then understand what the definition of freedom is. I think you should let them go and figure out what it actually means. And then if they understand, they will not do what they're doing. Anyway, Dr. Estes exemplifies the long COVID syndrome. Right? What she has described from October of 2020 is now January of 2022. That's definitely more than 30 days after the initial onset of COVID. That is the definition of long COVID. We still don't know how to treat long COVID. But based on what she has described, a lot of the pathophysiology has to do with the initial damage. This intense inflammation, also called a cytokine storm, doesn't go away, even when the virus goes away. It sticks around and damages the lung, so we call it interstitial lung disease. Sticks around and damages the kidney, we call it chronic kidney disease or some kind of disease. Sticks around and damages the nerve cells and causes all those brain fogs and all those neurologic issues, the tremors and all the stuff that she described. They are all remnants of this intense inflammation that the COVID left behind. I was so emotional listening to that story, even though I'm a doctor. We never want anyone to go through this at all. I think she will get better with the right treatment. I'll be happy to do a consult on biometrics. But it suffices to say that the audience listening today, you now have real proof that there is long COVID. If you are actually in the audience today, now you know there is long COVID syndrome. And now you know to talk about it, And now you know to tell people to make sure they don't have long COVID syndrome, right? So thank you, Dr. Estes, for sharing the story. Really appreciate Dr. Maxey, as usual, for always getting me engaged. I'm so sorry I couldn't be on video. I'm sequestered to finish a grant, that is why. but I hope to be able to join live in the next session also. So thank you very much.
So good. And let me just bring up one other thing. Dr. Morrow, how many Black chairmen of medicine of academic centers are in the United States? How many of you guys are there?
I mean, it's just probably a handful, maybe. I don't know. I think there is one at University of Michigan, Michigan. I don't know of another person, maybe one or two others, but that's about it.
And the reason I ask, we know that there's a gateway to medicine to create more physicians of color. And a big part of those are hindered by chairmen of medicines that are not comfortable with advancing Black physicians. And we know a lot have had problems. Ivan, do you know much about these directors that we don't have and we need of services? I know we've got Ron Bailey at in Louisiana as chairman of psychiatry. I know we have chairman at Howard and Meharry and the Black medical schools.
Oh, definitely, for sure, yes.
But in majority, Dr. Salafu is one of an exclusive club, which wasn't quite so exclusive.
Yes.
You've seen some of that, Dr. Walks, right?
Dr. Maxey, in my CV, there's one of those things that we hate to see. First Black person to do this, or first Black person to do that.
Yes.
And I remember sitting on the board of trustees of the American Psychiatric Association, and I didn't have much company on the board. So these are, it's important for us to recognize and honor the accomplishment of Dr. Salafu, and I'm glad that you brought it up. And I think we need to know where those folks are. We need to know that Dr. Salafu is where he is, and we need to know that the other person he mentioned is over at Michigan, so that we can support and encourage those of us who are blazing those trails and opening those doors. It's tough to be in those rooms when you're the only person that looks like you, and maybe you're the only person with your sensitivities and your sensibilities in those rooms. So, hats off to you, Dr. Salafu, and all the others like you, Dr. Maxey, Dr. Jordan, and others who have been the only one in the room. It's important that you guys got in there and stayed there, that all of us got in there and stayed there.
I have to remark that, and I didn't want to mention that the reason why I'm not on video is because I'm sequestered to send this $22 million NIH application grant to do exactly that. I want to use Downstate as the hub for training the next generation of junior faculty members to senior level. That is the grant, basically. So if the grant is funded by the NIH, we are going to use SUNY Downstate as the hub. Junior faculty members from across the country who are Black and brown will come to Downstate and learn the tricks to become me. Right?
Absolutely.
So that is the plan. And that is a huge application. And we hope that it gets funded so that we can change the landscape of biomedical scientists. That would make it to, impacting health disparities in this our beloved nation.
And let me just bring up one other thing, and I'm beating a horse on this, but I'm doing it for a reason. I trained at a place called Harlem Hospital, and the chairman of medicine was Dr. Gerald E. Thompson, who later became the provost of Columbia University. He was the second Black person to be on the board of regents of the American Board of Internal Medicine. And he sent me to Dr. Eli Friedman, who was chairman of renal at Downstate, where Sam Kuntz was chief of surgery. And the place was so racist against Sam Kuntz and others and me. And I never thought I would see somebody like Dr. Salafu come and take Eli Friedman's place and be chief of nephrology. And then he became chief of medicine as well as chief of nephrology. So this is just a big deal. And he has never refused to talk to a patient or consult. He's so humble, but so great. And I just can't take my hat off enough. Thank you, Dr. Morris
I
Salafou.
appreciate that. I appreciate that. Thank
Appreciate
so
you.
much. Yes.
Well, we're here almost at the end. Dr. Waltz, any final comments?
Yes, Dr. Maxey, thank you. One of the things that we got a chance to touch on today is the importance of the mental health piece with any significant, severe, or long-term anything that gets at you, that not only attacks your body, but attacks your spirit, attacks you, however, your soul, whatever it is that makes you, you. Serious medical illness gets to that. Next week, we are going to have Dr. William Lawson, who is one of the giants in American mental health, a psychiatrist who will be on with us tomorrow, next Sunday, to talk about mental health and some of the consequences of mental health, not only related to COVID, but just it's a big deal. It impacts us. So I want to invite everyone to be here next week to hear Dr. Lawson present. He was also one of the folks that Dr. Salafou mentioned that was a part of the International Symposium on Long Haul COVID. The last thing I want to say is I've been trained that whenever I say to someone, I'm going to pray for you, to just stop and do it right then. Because so many times we say that and something gets in the way or we don't get to it. And sometimes it's nice to let people know that you're praying for them right then on the spot. So of course, I'm going to defer to Reverend Pointer, but I would like us to take a moment on the Black Health Trust as we're closing out. And I think Dr. Pointer was probably going to do this anyway, but just to lift up Dr. Estes in the middle of her challenge, and our sister, Dr. Estes, because since we're all God's children, it makes us all brothers and sisters, right, Reverend Pointer? So that's what I have, Dr. Maxey. I think that we really have to focus on mind, body, and spirit. And I can't think of a better use of time than to pray with and for someone.
I think you're exactly right. And I'm so glad that you brought that up. So in our final words, and thank you, Dr. Jordan, for that suggestion. I'm going to personally work with Dr. Estes to do that. I have the honor of being her primary care doctor and prayer partner. And Dr. Estes, would you have a final word? And we are going to ask for prayer from Dr. Pointer, led by Dr. Pointer for you. We usually don't do that on the Black Health Trust, but it is so appropriate.
Thank you so much. I do definitely have a final word that won't take too long. I'm sorry I didn't catch the doctor's name, the psychiatrist that's online.
Dr.
You
Waltz.
are right. We have to pray. More importantly, we have to give God all the honor and the praise. And I cannot end this call without telling everyone on this line exactly what he has done for me. I told Dr. Maxey when I was on that table and they were doing my surgery, the surgeon was having trouble getting to the blood clot. And I heard him say, I had these periods of lucidness. And after his second try, he clearly stated, I'm having trouble getting to it. I can't do it. He said, I'm going to try one more time. And if this doesn't work, I don't know what else to do. I couldn't talk because of the stroke. And I knew nobody in the world because my memory was lost. The only person that I knew was God. So I started praying in my head to our Heavenly Father. And I said, Heavenly Father, please help me. Please guide the hands of the surgeon. Please, God. And in a few minutes, the surgeon screamed out, we have success. And I just broke out in tears and crying. And of course, they didn't have a clue of why I was crying, but I knew why I was crying because I knew what God had just done for me. And I find it just powerful, and just knowing how mighty and powerful that He is when I don't know myself. I don't know my mama. I didn't know I had kids, but I knew that there was a God there, and I knew to call on Him, because what I wanted to do originally was ask the surgeon, please don't give up on me. But I didn't have a voice. But in my head, I definitely had a voice, and my Savior heard me and He answered me. So I say that to say that everything that's going on in this world right now, believe that God hasn't given up, and He continues to uphold us all with His righteous right hand. He promised that He would never leave us nor forsake us. And I continue to give Him all the glory, because all of this is to boast so that He can get His glory in the end. And I encourage you all to continue to stay prayed up. And Doctor, you said, don't say, I'm going to pray for you. Do it now. You may forget later. Do it now. Stop at that moment and pray for that person, because you never know what impact you're going to have on their lives. And I thank you all for granting me the opportunity to hear me out today.
Good. We're going to go right to Reverend Pointer. I'm going to ask Mr. Dorsey, who's a deacon in Louisiana, to put his information in the chat. We are endorsing that people look at the machine that he says will help protect us. It's protecting my home and my wife and kids. Dr. Walks and Pastor Pointer, we'd love to
Yes, sir.
have you have prayer with us.
Thank you. I want to give thanks particularly to the Almighty today for what we have seen Him do for Dr. Estes. Additionally, we want to thank Him in the person of His servant, Moral Salafu, and we want to ask protection for both of them. But specifically, we want to ask for complete healing for Dr. Estes and competent care, that she would be placed in the hands of competent caregivers. Let us pray. Holy God, everlasting God of Jacob, the eternal God, the King of all creation, again, you have brought us to this hour. We beg of you, O God, forgive us for our sins, which we may have committed this day in thought, word, and deed. Cleanse us of every iniquity. Hear our God this humble prayer for your daughter, our sister, Dr. Estes. Complete her healing. Keep her in the hands of competent caregivers and guide their understanding of the challenges that she is continuing to face. As only you can, oh God, guide them in a way that will complete her care and grant unto her complete healing. We thank you for her soundness of mind and strength of spirit. Continue to protect her. We ask, oh Lord, as we move through the remainder of this day, and as we come into the hours of eventide, that you will grant unto us peace, that we will have restful sleep, that we will rise from our lowly beds to please your holy name, not only today, and if it's your will tomorrow, but all the days of our lives. Vanquish our enemies, both bodily and spiritual, that contend against us. Deliver us, O God, from evil. You are still Lord.
Yes.
Eradicate vain thoughts from us, that we might not be stained in this world, that we might not possess or develop evil desires. Grant unto us the glory that was given unto your Son, that we might speak and it would be done in his name. So we ask you in Jesus' name
Yeah.
to give us kingdom outlooks and the power and glory of the Son. And as we are your servants, we beg of you, O Lord, that you would not only walk with us, but that you would hold us in the hollow of your own hand and grant us peace. We ask these blessings in the name of the Father and of the Son and of the Holy Ghost, now and forever, and unto the age of ages. In Jesus' name, amen.
Amen.
Have
Amen.
a good rest
Praise
of the day,
God.
everybody, and thank you so much, Dr. Salafu,
Thank you.
Dr. Walks, Dr. Neighbor Stevens, Dr. Hines, Pastor Pointer, Dr. Jordan, and all the others who've joined us today, and bless you, Dr. Keisha Estes. Thank you.
Thank you.
Thank you.
Have a good day.
Good day,
Praise
everyone.
God.
God bless.
God bless you.
All right. Praise God.